Today's seminar. There's going to be a few more people that are outside that I'll join us shortly. Welcome. I'm Sue Flocky. I'm one of the Associate Directors of the Prevention Research Center for Healthy Neighborhoods. This is our monthly seminar. Glad to see so many faces here. If you've not been here before, welcome. There's a sign-in sheet outside. There's actually a couple of them. If you didn't sign in, please do that. Even if you signed in last time, we ask you to fill that out every time so we can know who's been here and how to reach you for future activities and events, as well as future seminar sessions. So today's session is a team effort, and what I'm going to do is just introduce all of the different speakers and hopefully get them. I won't get them in order, I'll put it that way. And then I'll ask them to go ahead and tell them a little bit about themselves and do a self-introduction, kind of what your role was on the project, and then go ahead and do your presentation. We'll leave a little bit of time for Q&A and discussion. We usually have a very rich discussion with this group, so I'm very much looking forward to that. Before we start, I do want to make a note that next month we have a national speaker that's been invited. It's co-funded from a couple of sources, but thanks to Dr. Erica Trappel for the connection in bringing Colleen McBride here. And Colleen is a very interesting person. I actually know her from way back when she was doing tobacco work. But she's going to be talking about using genetic information to motivate healthy behaviors. That talk will give you plenty of heads up on that one. It's going to be on campus. It won't be in this space. But we'll give you plenty of heads up. It'll be in the same time slot. Okay, so back to today's presentation. We have 5 presenters. I believe the first presenter is going to be Stephanie FallCreek, who is President and CEO of Fairhill Partnership. We have Jonathan Weaver, who is Project Manager for Better Health Partnership. Wanda Ali-Matlock, who is a Senior Consultant for Better Health Partnership. We have Samantha Smith, a data analyst from Cuyahoga County Board of Health, and Delores Collins, who is the founder and executive director of A Vision for Change. Okay, so lots of folks who have really interesting things to tell us about this project. Looking forward to it. So with that, Stephanie, please get us kicked off.
Thanks, I appreciate that. All right, the blue light's on. It means the recording is going. Welcome to Chronic Disease Self-Management Workshop Referrals. All through the rest of this presentation, that's probably going to be referred to as CDSMP, right? But then there is also DSMP, which was a part of the project, Diabetes Self-Management Program, and somebody else will introduce you to something that's very deep. So we're going to talk about what we planned, what we did, how it turned out, and frankly, from my perspective, the most important part of this presentation is what we learned from it. From many years' experience, the things that you learned that didn't go quite as well or didn't go the way you expected them to are some of the most valuable lessons that you can get. We're going to talk a little bit about background. We're going to talk about what our initial plan for referral systems, lay leaders, and workshops was. Then we're going to talk about what really happened, our evaluation process and our outcomes, the lesson we learned. And it's always wonderful when you are moving toward the end of a grant process to know that there actually are next steps, that there's a plan for how to learn from the lessons that you say that you learned and continue what was good work there. So Cleveland is clearly one of the most health source rich environments in the country. We have great health systems, we have tons of clinics, we have internationally known healthcare experts, providers, researchers, and everything else, and yet there is a tremendous amount of health disparity, and like everywhere else, a tremendous amount of chronic disease. Supporting self-management, that is, a person's active participation in promoting their own health, is absolutely essential for prevention, for risk reduction, and for managing chronic disease. The resources for teaching people how to self-manage, and one would wish that we didn't need to learn how to self-manage, but in fact, a whole lot of things about our healthcare system actually have encouraged us to abdicate responsibility for self-management and turn it over to someone else. And so the resources for self-management for everyone are somewhat scarce. And the lower the income, the higher the ethnicity. Just take it, the greater the health disparity, the fewer resources there are for what we like to think of as evidence-based self-management education. So, I don't know, I used to say 30 years ago, I guess it's now about 35 years ago, Stanford began seriously doing research on an entire suite of self-management programs. CDSMP and CDSMP, they've been demonstrated nationally and internationally to be effective. But again, when it comes to working with specific populations in specific neighborhoods in specific circumstances, we still have more to learn. HIP Cuyahoga, the partnership, developed a community clinic linkage model to both enhance access to and hopefully follow through, known as uptake in these circles, right? Follow through on referrals to these self-management workshops. There were 7 neighborhoods that comprise, am I right, 21 census tracts? 20 how many?
22.
22 census tracts across our city. And although Fairhill has been doing work in Cuyahoga County and Lake and Lorain and Medina counties since about 2006, we actually had done very little work in the 22 identified census tracts. A couple of isolated workshops here and there, but not very many. And we'll talk more in our lessons learned about why that might naturally have occurred even before this project. So this is sort of the partnership, if you will. Healthy Neighborhoods, the Better Health Partnership, the Board of Health, Fairhill Partners, Creating Greater Destinies, and the project is REACH, funded by the CDC, and we are in year 4 of what we think is a 4-year project. So here's the overview. We thought we were going to be a 3-year project to begin with, and so there it is. It was a clinic-to-community linkage strategy that began in 2014. The 7 neighborhoods that were identified were South Collinwood, St. Clair Superior, Huff, Central, Union Miles, Glenville, and the city of East Cleveland. Within those 7 neighborhoods, clearly there were lots of healthcare resources, but there were 7 safety net clinics identified. These clinics represented the various health systems in Cleveland: Metro Health, the Cleveland Clinic, Neon, Northeast Ohio neighborhoods, Care Alliance, and St. Vincent, serving those communities. Our overarching goal was to increase resources for the residents of these neighborhoods to self-management education by creating a referral system from the clinic to the workshops, by training lay leaders from the neighborhoods to lead some of the workshops, and by hosting workshops both in clinic and community settings within those neighborhoods. So this was our initial referral plan. The referrals would come into Fairhill Partners, the big green spot in the middle, from all of these different sources, from the targeted safety net clinics, from advertisements, and from resident teams or directly from residents themselves, whether it's self-referral or from recruiting potential workshop leaders. So those referrals would come into Fairhill, and because this project did not fund the implementation side of the workshops, we set up workshops as we ordinarily would, trying to target and set those workshops up in sites that were identified in the target neighborhoods, and we would place people, that means we would encourage people to place themselves in workshops that were in their target neighborhoods. And then Fairhill also trained the workshop leaders that came through the resident team process. And in the end, all those referrals, both of lay leaders and of residents to the workshops would go to the self-management workshops. Those were scheduled and led by trained leaders. Some of those leaders were lay leaders from the target neighborhoods, and some of those were leaders from across the area where we simply needed to be able to find people that could do something at a particular time from Fairhill's pool of lay leaders. And then the workshops were attended by both patients and residents who were referred. That was the initial plan, and to a large extent it sort of happened in one way or another, and you're going to hear more about what then happened. Okay, so with our referral systems, I'm going to turn it over to Jonathan, who is going to get into the nitty-gritty of reality.
Thanks, Stephanie. So I'm going to give just a brief overview of what happened in reality from the three areas: the referral system, the lay leaders, and the self-management workshops. And then the rest of the team will dive into different specifics. So initially, we were tasked with setting up these referral systems at 9 clinics. And this was a challenge, right, because we were not only working with the clinical teams to do work with them, but we also had to work with the legal teams. We had to work with the IT teams because we had to create a business associate agreement between Fairhill Partners and each of these health systems. And then in addition, we had to work with the IT teams to build some tracking mechanisms in their electronic health records. So some of the hurdles that we faced were mainly around time, right? So it took a long time to get through some of the legal hurdles, the IT hurdles, and then actually working with the clinical teams. There was great success, though, once we got past some of those legal hurdles, but they were needless to say, a bit challenging. We did have referrals, when we did passive advertising in the community. Those typically didn't really produce many referrals that we had hoped, and so we had a lot of great work from the team at the Prevention Research Center and the community fellows that were on the ground to actually get out and get the word out. And the one thing that actually I wanted to start this slide by saying was that I think one thing that was really unique about this project is the way that each organization that was partnering had a unique role, and we could not have done it without one another, if someone was out of the mix, right? So Better Health Partnership had a kind of a lead role with working with the clinics. The Prevention Research Center was instrumental with and very pivotal with finding sites in the community, getting residents. We couldn't do it without Fairhill Partners, of course, because they had the license, on. And then, of course, we had the residents, which were actually even further on the ground. So I did want to mention that. In terms of the lay leaders, we had initially planned that a lot of some of the community residents would be the ones leading the workshops, and of course we did get community residents that were trained, but probably less than we would have liked. But the Fairhill staff was very instrumental in getting the workshop set up and so on and so forth. In terms of the self-management workshops, we had scheduled multiple workshops. Oftentimes they needed to be rescheduled because of there wasn't follow-through at the site, so we had sort of some site issues. We couldn't get buy-in at the sites. We scheduled a workshop and then maybe not enough people attended, so there was some kind of hurdles from that aspect. We ended up adding something called DEEP. So I'm the person that's going to tell you about DEEP, as Stephanie was mentioning. So DEEP is Diabetes Empowerment Education Program. And one of the main reasons why that was added to the mix is one of the health systems that we were working with had gotten a lot of people trained in DEEP, and that was a workshop that they preferred over DSMP. It's a little bit of a different model. It doesn't require 2 lay leaders to lead the workshop. It also doesn't have sort of an attendance requirement around how many people you need to start a workshop. So it was favorable, and so we adapted with what was going to work for the workshop, for what was going to work with the health systems. Overall, we met all of our targets. although we all have a bit of bruises and battle signs to show for meeting those targets. Further, what happened in the clinic, I mentioned we established these business associate agreements between Fairhill partners and each health system. We had to create the electronic health record referral. It was not a true referral, electronic health referral. It was essentially a fax referral, but it was a mechanism for the health system to electronically capture those referrals in their EHR. And you'll hear a little bit more how later in the discussion how we're actually kind of taking that electronic referral to another level. We developed these fax referral forms, guidebooks, presentation programs, training materials, advertisements in the clinics, to spool up the clinical teams. We did trainings. We met with the staff. Wanda did observation visits, our practice coach, really trying to get on the ground in the clinics to support this. And one of the things that was unique about this project was this was a referral to a community resource, right? So that's why we're calling it clinic to community linkage. And this was a real shift in provider behavior because they're used to referring people to gastroenterologists, endocrinologists, cardiologists, but when you say, could you refer to this community workshop, it's just a very a strong change of provider behavior. And so we had to kind of think through, from a clinical team perspective, who has the time in their schedule, who has the ability to do those kind of referrals. And what we ended up with were the nurses and the medical assistants is where we got work done there. The picture up there is just one of the advertisements that we kind of had in the clinical setting to try to draw people in and get some engagement from patients. In terms of the referral process, there were basically two methods that we employed. One was by the nurses and medical assistants, and essentially they were referred at the time of triage. So when the patient came in and were having their vital signs checked, we were basically targeting patients with elevated blood pressure. So per the hypertension best practice, they would receive their first blood pressure. If the reading was greater than 140/90, they would receive a second blood pressure reading, and so if they had the elevated blood pressure, hypertension, the nurse or the MA would engage with the patient to see, tell them about the program, see if they were interested. If they were, they would complete the fax referral form, and then that would be sent to Fairhill Partners, and Fairhill Partners would take it from there as far as contacting the patient, getting them engaged. At another health system, the other way that it kind of went down was using a registry. So a registry is basically a list of patients based on criteria. So in that clinic, they pulled patients that had diabetes and a hemoglobin A1C of greater than 8%, and they would call those patients, assess their level of interest, tell them about the program. And that health system actually had a referral. Their fax referral was actually kind of embedded. So it was a little bit more integrated, so as soon as they faxed it, it got to Fairhill Partners. Both systems, we got patients from a clinical perspective, from a workflow perspective. I personally think that the outreach based on the registry was easier for the clinics because they weren't doing it one at a time, each patient that they could just kind of sit down and make a whole bunch of phone calls and then move on to their other sort of tasks. So I think Wanda's going to talk next to tell you more about the clinic referrals.
Well, thank you, Jonathan. Well, I'm Wanda, and I am the one who was involved with the practice at the practice level. My role was make sure they know what to do and how to do it and to do it correctly. And what you see on the screen, we have our practices listed from A to E because we want you to know who they are. But in essence, as Jonathan mentioned about the three methods for the referral, as you can see, there's one system, System A. They only did referrals by outreach. And as you see, 13, you may say, that's not many outreach. But really, that's the ones that they actually contacted. And that's the number that they gave us, where they may have made a lot more, but they didn't track that for us. Then you may see for Health System B, they did outreach as well, and they only outreached to 30. And then we had System C that did outreach based on a registry as well as a referral. And their outreach they outreached to 879, which is a nice number. And then for their clinic referrals, they made like 52, and that's when the patient came in, the MA or the nurse would talk to the patient, tell them about the CDS-MP program, chronic disease self-management program, or the diabetes program, and get them to buy into it. So when you look at these numbers, you may say, wow, that's a lot. I'm sure you had a nice turnout, you had all the people that you needed, because we know that there's a lot of chronic disease right here in Cuyahoga County, but we'll tell you a little bit different story. Also, I want to let you know, all the practice had flyers. We developed these flyers, and they hung them up in their office. They put them in the waiting area, put them in the triage area where the exam room, so that the patient can take the flyer. We did have one practice, Health System D, and they only method for connecting patients with the chronic disease self-management program was through the flyers. And we can see they have made like 310 contacts for the patients with them. So if you total all that up, you probably have like, what, close to a couple thousand patients with chronic disease that may have had some contact or an opportunity to come into our CDS-MP program. But I'm going to tell you what really actually happened. You may think of all of those patients and all of those referrals and all the chronic disease management that's floating around, we really had our numbers, but we didn't. According to the Stanford model for this chronic disease self-management program that Fairhill Partners is administering, you have to have at least 15 people. So you say 15 people, that's not a lot. You divide all the people that they had the outreach for, you can probably have 10 to 20 classes, but we did not. So really we had a low number of referrals, and what happened is some of our classes we had to either cancel or delay, and we even did what we call like a class zero, meaning people came, but because we didn't have enough, we don't want to waste your time, we'll let you know and we'll schedule for another week to try to get more people. But we did work through where we were able to get approval, as I would say, where we can have like 10 people. So we did run some programs that didn't have the full 15. The other thing that was, what we ran into was that it was really very hard, and as I said, my role was to be actually in the clinic with the doctors, with the nurses, with the MAs, and helping them to create their workflow so that this can actually happen, because you know it's always a barrier. When you add something new into the practice mix, it's like, my God, you asked me to do one more thing. How am I going to do it on top of everything else? So my job was to help them to figure out how they can incorporate this chronic disease self-management referral process into their regular workflow. And it always didn't go over very well. And as Jonathan mentioned, when we help craft some workflows, we help craft some training manuals and some guidebooks so that they can help really incorporate it and really own this process. The other challenge that we had was really the documentation, which really made a nightmare for, and you'll hear from Samantha, who did a lot of our analyzing of our data, and it was really hard to try to reconcile, because what happened is the clinic may say they sent, I don't know, 1,000 referrals, and then Fairhill Partners maybe only had 2 or 3. So the question is, what happened? Or vice versa, they would send referrals, the clinic would have patients listed for referrals, and the patient would say, I didn't say I wanted to go, you know, where did that come from? And or when Fairhill Partners reached to try to let them know about the class, the number was disconnected or the patient wasn't available, so we ran into those barriers. Also, part of our work was with this chronic disease self-management program, is to make sure that there's lay leaders, as we call them, and you'll hear from one of our lay leaders, who is also, I think, Ms. D, a master trainer. So what we did manage was to train 101 lay leaders, which is, I would say, applause for us, with all the struggles. But also, the difficulties, we had to change our, I would say, programmatic definition, because the goal was to train people that actually lived in the reach neighborhoods, and that's your East Cleveland, your Glenville, your Collinwood, who would become lay leaders and really hold the chronic disease self-management workshop. And we didn't get enough of that to administer the program, so we had to expand our definition to include people outside of the reach neighborhood, but was willing to work and serve in the reach neighborhood. And that's where we ended up with our 101 lay leaders, and 7 of them are now master trainers. What you see here is like a little postcard, and we call that a hot card, and that was one of the tools that we use to advertise. And this is what our I would say our community partners, those who are on the boots on the ground in the neighborhoods, our residents, use to help talk up the program, because we needed to know. And just having it in the clinics and letting the clinic staff do that really wasn't enough. It had to be people that maybe didn't go to the clinic that really can benefit from it. And as you can see, if I can get this little pointer to work, this young lady here, Ms. D, and she was really a trooper, and I don't think we could have done a lot of this work without her, and you'll hear from her. But this is just one of the tools that we use to try to get the word out, advertise, let people know about the chronic disease self-management program. So I'm going to turn it over to Samantha, and she will tell you a little bit about some of this data stuff.
All right, hopefully I'll take some of this home here. So I'm Samantha, I'm from the Board of Health. I'm a member of HIP Cuyahoga, our program manager's here too, but so we are, as an organization, we're the backbone of HIP Cuyahoga, so kind of drew the partners together at the very beginning to get this thing started, and then obviously managed the project overall, and then also provide evaluation support. So we talked about trying to get the referral systems in place and actually get some folks referred. So we got that done, maybe not exactly as planned, but people funneling through that way. We did get some leaders trained, not all residents like we hoped, but we got a pool of them going. So do we actually get the workshops going? Our target was 9 workshops. That was just basically in the grant. It was in general, we were trying to do at least 1 per neighborhood. I think the number 9 came from 9 clinics. We reached out to 43 sites, and so there's 2 tables here. One kind of shows the neighborhoods, the sites by neighborhood. The other one shows the site type. So you can see kind of a variety of sites there. Initially, we started working with the clinics just because that where the referral build was kind of happening. So naturally, we were saying if they had a spot there, they have the patients, maybe it'd be easy enough to host a workshop there. Throughout the grant, that kind of evolved a little bit. One, due to our reporting requirements. We kind of had to start counting them differently and specifying we will do this many in community, we'll do this many in clinics, so we had to kind of reorient our focus. And then also part of the larger REACH grant that we were under, another goal was establishing shared use agreements, which are kind of trying to get community sites to open their doors to the public after hours so they can use them for physical activity workshops. So as those sort of funneled into our larger project, we also kind of zoomed in on those sites and saw if maybe they'd be willing to host. A couple points I want to bring up about just the numbers on the slides here. So I said we reached out to 43, so both these tables hopefully should add up to 43. But on the neighborhood side, I sort of want to point out that I would interpret this table not as necessarily saying, oh, there were so many sites in those high numbers, East Cleveland and Union Miles. I would interpret this more as that's actually where we maybe struggled a little bit more, and we had to reach out even more sites just to land 1 workshop there. Particularly in Union Miles. And East Cleveland, that number maybe is even a little higher just because we actually did manage to have 2 workshops there, so we had engaged more sites in that respect as well. And then the other side, just trying to show the diversity again. Obviously all the clinics we worked with, we did not have a workshop in all the clinics, but we reached out to all of them. And then kind of you'll see the sites, maybe we had more success, there's more of those, for example, housing complexes. And then, we were trying for everything. We had a connection to a dry cleaner that had a facility, an extra site, and hey, it's a spot. Didn't work out, but. So again, next steps, so what actually happened? So 43 sites, like I mentioned, we had 4 of the 9 clinics. So top table is like what happened to the sites. The bottom table is then the workshops. So 4 of 9 clinics actually held a workshop, and 7 of the 34 other community location sites. So kind of a various breakdown of things happened. Some of them, after we, somebody said, what about this site? And we kind of reached out or saw it or got some more information. We just determined that they were kind of unsuitable for the program itself. Maybe the facility wasn't big enough. Maybe there's no parking. Maybe they had a cost associated. Boom, like ruled it out. As far as then, we kind of not fully pursued. So another chunk of them, kind of what happened here, we had a recommendation, maybe got in contact or tried to contact a person at that facility, but then in that neighborhood, we got a site. And we're like, okay, zoom in, we got this one, we're going to let this one kind of deprioritize because there's only so many people on the team, only so many balls in the air at one time. So, maybe these ones, if we had a few more years, we could get them on board, but they just kind of naturally became less of a priority. Then there's a big chunk, about a quarter, that we needed some neighborhoods, and we bugged them as much as we could, and nothing. Either they said, like, yeah, maybe, and just no other follow-up. Maybe they never responded to an email or phone call, just, so obviously that's a consideration in doing this all yourself. There's just, sometimes you can't make it work. Then we had a small group there of 4, which we got to the point of having workshops scheduled. We had the time, date, we had the leaders assigned, and then there just wasn't enough people that came. And so those are like the heartbreakers. It happened a lot at the beginning, so, but, keep pushing on. You finally got 11 sites total, and so again, when we started this off, it was a 3-year grant. I would say the first year was mostly planning, getting the team together, all that, so workshops didn't happen until like the second 2 years, so this is kind of in a 2-year view. We were able to get 11 sites, so about a quarter of the ones we reached out to actually host a workshop that was successful. So then the bottom table talks about the workshops themselves. So out of the 11 sites, we had 14 successful workshops. So obviously a few sites had more than one. I do show the number there, just out the breakdown of CDSMP, DSMP versus DEEP. We added DEEP later. So it shows just the number successful by neighborhood. So we're pleased to say we did hit all our neighborhoods with at least one workshop. And then the site column just shows that sometimes we were able to do one in a clinic and community, or sometimes they were 2 different community settings. Sometimes it was the same one clinic, like in Huff. We got the same clinic to do 3 workshops. So this kind of just a few other notes that beyond those data to talk about. So most all the workshops were scheduled daytime, and usually we did kind of avoid the winter months. So, I mean, I don't know, maybe that was for the best, not for the best, we don't really know, but it was a strategy we approached. I think I talked about it later in lessons learned. And some of this other stuff I did too. But so for successful workshops, we did try to kind of learn over time that captive audiences were the locations that were key for us. So one is kind of the clinic locations we had some success at, just because there's a pool of patients there and you're not asking them to go to yet another location. They're familiar with that site, kind of worked out better. The other one over time was apartment buildings that were senior complexes. So that's a community site, and there's a few hundred folks there that are older, have chronic disease, and if they don't have to travel anywhere but downstairs, like sometimes those were our winners. So that's a big lesson we learned. And then there was also like a rec center that maybe already had some programming, or maybe had other kind of workshops, and we could pull from those workshops into this one. So those are these captive audiences that we thought that was like a big key. Having a champion. So we didn't figure this out exactly, but it helped logistically. If there was someone there at the site that was willing to organize the room and the time, and maybe try to recruit, or maybe try to hand out some flyers, and that didn't even always work. There were still some of those 4 workshops that didn't work out, but I think it's an important piece. It just didn't guarantee. Resident involvement at the site. So obviously we were able to get some residents involved, and definitely helpful. They helped with recommending sites that maybe we didn't know about. When we got smart enough to ask them for help with recruiting, they went out into the communities and handed those hot cards. So that was a big help. Regarding the workshops themselves, so we did have success both with CDSMP and DSMP, which Jonathan Wanda mentioned, have more of like a stricter protocol. So they're both 6-week workshops, 1 session a week. I think they're 2.5-hour sessions. So we're asking a lot from these people. But the CDSMP had like a more strict criteria as far as the license. Like I think you had to have, like you said, like a minimum 12, and you can't be over 16, so you have to have like this exact correct number of folks. Versus DEEP, you can really, I think you're like technically allowed to have like 2 and still run it. So a lot more flexibility. That helped us out as far as accomplishing our numbers. So to tie this hopefully back together then, so you saw we were up over, I think it was near like 1,500 referrals or something from that referral slide. And again, some of them were like more of the official clinical referral, we kind of labeled it. Some were more of like the outreach, so maybe that's like a second tier. Then we had the clinic that was just kind of like flyers, I don't know, that's like sort of the weakest approach. But anyway, a much smaller number actually registered and attended the workshop. So we got 133 folks. Again, this is that two-year window. We have more activity going on this year, so it'll go up a little bit. But sort of good news is, I think I'm proud of this number at least, that if you can get them there, you can engage them, and we had almost 2/3 that actually completed. So we did kind of build into this process, even though, as Stephanie said, that these programs are considered evidence-based, and there is a lot of research supporting that they help folks manage their health better, or be more engaged during their visits, make goals around healthy eating. We wanted to kind of focus in on our population and see, if we affected them. So if we were able to get the clinics to refer, if we were able to get leaders to host these workshops, if we were able to get people to actually show, was there a benefit to them? So we had a survey, surveyed folks at the first session and the sixth session, or the last session. What do I want to say about this? Okay, so this is only the CDSMP, DSMP data. The deep data was kind of from a different source, so we're still merging that in now. So that's why this number is smaller. Also, obviously, there was attrition, so not everyone completed a workshop, so those people got kicked out of this data set. And then there's a few people we didn't have, say, a pre-survey if they started at session 2, which was allowed. So a completer meant they completed at least 4 of the 6 sessions. And I think I did put some demographics in here, just so I don't have it on the slide. But that kind of confirmed we had kind of reached our target audience. I think about 2/3 of the folks were females. Average age, I believe, was around 65. Percent African American was over 90. Over half had high school education or less. And so then these were kind of the 6 main measures we put in there as kind of an assessment of chronic disease self-management outcomes. Some of these measures, obviously, we were looking for kind of an increase. Some of them we were looking for a decrease. So kind of the green little ones I put as here's where it was kind of trending the right way. The red one was maybe a red flag, but again, these are pretty small numbers. So these are trends. This is preliminary data. Like I said, it's just CDSMP, DSMP, doesn't have deep. But general health, we saw some improvement. Great. Quality of life was something else we wanted to go up, and we see, maybe a little bit, but perhaps not too big a change there. The pain, this one's a tricky one. Right now, obviously we wanted their report of their pain to go down. Unfortunately, we see it go up. I do think in this case it's an issue of a small sample and small numbers, because as I added cases in, this number flopped both ways. Sleep problems, we wanted those to go down. We are seeing that trend. I believe that is significant even with the small numbers of cases. Chronic disease self-efficacy, so how they feel about it, their confidence in being able to manage their disease. Obviously, we're hoping for that to go up. We're starting to see that trend. And then depression severity. And again, these are kind of established measures. We didn't make them up on our own. But this was a score, and this was another important one for us. And indeed, we are seeing, or we did see that it looks like from pre to post that depression severity went down. Okay, so lessons learned. We're almost done. Now this is trying to tie together. We talked about each little piece, so this kind of talks about all of them together, what we think we learned from all this. So first takeaway, biggest takeaway is this is not easy. I don't know if the writers at the beginning thought this was going to be easier than it was. A lot of time, a lot of effort, a lot of partners. Anyway. The referral systems, establishing there. Jonathan talked about slow process. We had strong connections to the clinics, but we weren't a provider in the clinic. We weren't staff in the clinic. So we weren't necessarily top priority for anyone in that clinic to answer our email, to answer our phone call, to say, hey, did anything happen with that IT build we talked about a month ago? Just slow. And then as we learned more, obviously we knew, I guess maybe at the beginning, that there was some legal and paperwork and all that, but we kind of understand more the slowness of that, the amount of hurdles that each clinic's legal team might view it a different way and want another form or another agreement with Fairhill. Definitely had to consider that in the future, plan that into your approach way up front. But yeah, it definitely slowed things down. But we had some success. Halfway through, maybe we didn't think we would, but we did. So keep trying. We think we made our job a lot harder by dealing with so many health systems at once, because again, you have different administrations, you have different EHR types, and then we layered, the even greater challenge of and we're just going to do all safety nets. Those are the neighborhoods we want, those are target populations we want, but folks there have way lower capacity, staff turnover, all these issues. So I think it just made things harder. In regards to the workshops themselves, again, that takes a lot of effort. We had that nice flow diagram that we had these 3 referral sources, so clinics, advertising, and residents, and that was going to funnel everyone in. And then we'd have these sites to be able to slot everyone. So obviously we learned that it's an uphill battle to get sites. What kind of actually made it even harder was that these timelines need to match up exactly. So you can get a site and you can get a date, but if you don't have enough people to be there from referred at that exact month that you scheduled it, then you need to like bump it back a month and still get all those people to come. Think about that. Think about that ahead of time. Community resident support. So we'll talk about this, and we're going to hear very soon from one of our rock stars. But if you can, build them in, ask for help, ask for site ideas, help recruiting, anything helps. Easy one, over-enroll. So again, it took thousands to get, what do we get? Like I said, 14 workshops, but if you think you're having 15 to show up, you're not, you get 10. And you don't want to fall below the number that you're required. Champions. So I think I mentioned this, that at the clinics, we feel it's an important piece. If there was someone there to really just help, like give you the okay that the site's there and it'll be unlocked and there's chairs, whatever, that helps. It also helped at the clinics. I feel like there was someone maybe pushing people within to kind of make the referrals and not forget about us. Obviously Wanda, I think, was critical in that respect because she was there. But if you had someone that was kind of a champion provider willing to do referrals, that pushed more in. So both, again, at the clinic side and at the site side, a champion is ideal. The captive sites, talked about this, but I think that's one of the big take-homes for us. I don't know, maybe Stephanie from her experience just with these programs in general, but I think for the team, we really shifted that way and had a lot more success. Data monitoring, so we did our best to try to track all these different elements, and we had data streams coming in from clinics, data tracking at Fairhill, survey data, actually another provider when we started getting the deep workshops going. So that was a hurdle as well, to try to keep track of everything we were trying to keep track of. And I would say data monitoring was key there. To be honest, things didn't match up exactly like Wanda said. You'd have a clinic site that said they referred 50, but maybe only 20 forms got faxed to Fairhill. So, did they not fax them? Is their query wrong? And vice versa. What happens when you got more faxes than they documented? We think it was just them not documenting, but. So yeah, we did the best we could with what we know, and some. Okay, this one might be controversial if I want to put it in there. We did experience some hesitancy, it felt like, at some sites to refer to self-management. And, next study, maybe you look into why. We don't know why. Maybe it's just competing demands during that visit. They couldn't make time to talk about this too. The shame of it is that, this type of programming kind of encourages folks to become a better patient, teaches them about medication adherence, teaches them about how to ask questions to their doctor, all this. So in theory should make the healthcare visit easier, yet it seemed like there's little resistance to them referring patients to self-management. Haven't figured it out. So maybe competing demands, like I said, maybe there's this element of perceived competition, not sure. Maybe just patients weren't interested. Maybe they did try to talk when they weren't interested. We're not sure, but I think it's an important take-home point. And then lastly, just we made it happen somehow, I don't know how, but we made it happen. Team effort, definitely, and not giving up. So as I think we mentioned at the very beginning, we did hit our workshop target goals. We were able to recruit or train a number of lay leaders. Obviously, I think one of our weaknesses was that we didn't necessarily have all residents as leaders. It was a very low proportion. But when we got some, and for the some we did, they've been very engaged, and that's what we're going to talk about next. And from this total package, we do see that we provide some benefit to residents in these neighborhoods that really hadn't had this opportunity. And we see it in the outcomes, the self-reported outcomes, at least to some extent. And then there is an indication that the residents do want this type of programming to continue, which takes me to next steps. So I'm just going to write off the first two, and then Ms. D is going to take over. But So we were awarded a 4th year, a supplemental year, to kind of try to continue and try to work on sustainability efforts and things like that. So one of the main things we're working on, or kind of Better Health Partnerships taking the lead on, is we're trying to see if we can work with United Way 211, and we're piloting in one clinic, building an electronic referral to United Way 211. If they refer patients there, patients get assessment about social needs in general, but they can also get their referral to CDS-MP as well. So it's perhaps a more familiar entity to clinics that they might be more comfortable referring to. It's going to offer potentially more connections to patients that are referred, and then hopefully still a pool of people that end up opportunities for self-management. The second, and again, we're working on this year, they're working on like literally the technical linkages between an EHR and United Way system, and it'll be awesome if it works. The second thing we're working on this year, we did want to see if we can get some of the workshops sustaining, and since trying to put all the pieces together is like a lot of effort for the team, we're honing in on trying to get the clinics to continue themselves. So you saw like a few sites back, there were sites that kind of had multiple workshops, and that almost like at some point, it was amazing that they started that on themselves. They had maybe a provider, they got trained as a lay leader, and part of his role, or because of the direction of the clinic, the administration, kind of prioritized it. And so we're trying to encourage that too. If they're willing to have a workshop at their location and kind of do all the logistics themselves, and maybe Fairhill just has to provide a lay leader, like that's, you know, that's a model that works for us. And then the last piece, which may be the most exciting piece, is, okay, so we talked about engaging residents, and Miss D is going to come up. Miss D is a resident team member. She's from Glenville. And as part of this process, she was trained as a lay leader, so she's certified lay leader in CDS-MP. And I believe she also just got her certified health worker, that community health worker certification, just because she's like amazing. And so she's really, at the very beginning, one of the partners talked about was CGD, Creating Greater Destinies, which was part of, again, the larger REACH project. One portion of it was trying to get residents tied into this project. And she's also really rose up and been like the leader of that group. And so as part of that, they have some ideas to how hopefully try to continue these workshops in the neighborhoods with resident connections.
Thank you, Samantha. Thank you. And as always, I'm super excited about any work that I do in the community. I've been doing this work for since '93, prevention and intervention with a lot of families in a lot of these different neighborhoods. So my role with this work was to help increase cohorts of trained residents. These are community health workers. They were trained through HIP Cuyahoga. These are also a group of individuals who have been doing this work for many years in the community. Whether they were called ambassadors or not, they've been doing this work, and we call them boots on the ground. So through the HIP-C training, you know, Don Slocum reached out to a lot of his alumni, and we took this training through HIP-C, and it was a wonderful training. And this is where I went to met Stephanie, first of all, and myself and Miss T, you know, we were so anxious, we ran to go take this training because we wanted to see what it was about. So I'll tell you a little bit more about that. But some of the other people that's part of this work is the community health workers. These are some students at Cleveland State University. And they are also some individuals who come from the community. I pulled some of our Creating Greater Destinies members right into this. So now they are community health workers, and they're on their way to becoming certified community health workers. So this is a great thing. We're going to continue to host licensed community-based self-management workshops within our community. And I'm so excited about as far as the flexibility, because that was a barrier for a lot of our residents and our community health ambassadors and community health workers, because they work during the day. You know, a lot of them wasn't able to go in and, you know, do these workshops. They're really eager to get them done, but to allow us to do this at flexible times. So now we can set some of these workshops in the afternoon, especially on the weekends, and in the evening. So we're really looking forward to doing these workshops. So we are also, I'm actively recruiting. This could be done at, and this is me, y'all, I'm just out there. I'm going wherever the people at. You got to go where they are. So we could go to the community meetings, different council meetings. We went and a couple of the council representatives went and shared this information with them, because a lot of them didn't know that, you know, they were even doing these different initiatives. So my point was, no, we got to let them know that we are here and this is what we're doing, and how can they assist us as well with this project. Some of our local businesses, whether that was some corner stores, that we got little gas stations, different things like that, it's going in there. We got little mom and pop restaurants, it's going in there, introducing ourselves. And in a lot of these neighborhoods, some of us already have relationships with a lot of these individuals. So it's just going in there and, you know, leaving flyers, leaving our little hot cards, you know, even talking to people that may be in customers, some of their customers, just talking to them about it. We have different locations in our neighborhoods where we do the fresh produce drop-off. We call them our food distribution centers. It's going there and really engaging in a conversation with the residents. And you know what? You'll be surprised. Once you start talking to them about these workshops, they are really interested, and they really care about their health. You know, they really do. So this is a great thing. And also some of the street clubs. You know, you get to meet a lot of people in this work. So just being able to spread the word in so many capacities. The plan is to use REACH shared sites. These are churches. Some of them are community resource centers. I want to say community centers, because the resource centers and our community centers sometimes are two different things, places. They could be the treatment centers. These are markets, and even some of them are schools. And our ultimate goal is to have neighborhood residents leading this workshop. That right there is like something that when I first was introduced to it, this is what I saw, a team of us going out and educating the residents in our community. So I'm just really excited. And before I close, what I would like to say, something that motivates me on a daily basis is that we are the source of change. We are, all of us in this room, all of our community health workers, all of our ambassadors, we are the source of change. When we change the way we look at things, the things we look at begin to change. Thank you.
Those page through, so the last, there's who we are, and thank you. If you have questions.
Open it up for questions.
Yes. So thank you for sharing. So thank you for sharing. I am Patricia, and my colleague Nancy Akeley. We just presented very, very similar findings with our clinical community linkages work. So you're not alone, right? So it's tons and tons of effort. And, you know, we're learning from this process, I think, because the CCL work is so new. We have the theories, we have it in in great models and great frameworks, but we're still not getting those magic key pieces moving from paper to practice. So thank you so much for sharing your findings with us.
Yeah, I was just saying, Patricia, can you just say, because I don't think everybody might not know that REACH, there was a second REACH, well, third, but just
Yes.
how did you guys do community clinical linkages?
Yes, I definitely don't want to take this away. Nancy chime in. So we have been working with 2 FQHCs, one federally qualified health centers, one on the west side, one on the east side, implementing, originally we wanted to implement the YMCA Diabetes Prevention Program, and that's a year-long program. And we found out probably year 2.5, year 3, probably year 2.5, it does not work for those communities. YDPP is very successful in some of our suburban, more affluent neighborhoods. And then we have been creating the Growing Younger Together program, which is modeled after the DPP. However, it is 10 weeks in duration at 2-hour weekly intervals. And we had, very briefly with our West Side FQHC, we reached out to 492 patients. And when you see that breakdown, like how many appointments were scheduled, how many attended the appointments, how many showed interest, 2 people completed the program. So, but 4 started out. 4 started the program. Or we could say 0.4% of the 492. We had tons of fun with numbers. Yeah, and so we're currently working at an East Side FQHC, and we modified the program because some of the staff was very interested in this work before they can truly get that buy-in to their clients. So it is part of their worksite wellness project. Who would have known? Unanticipated consequence, right? And that's going well. So it's going well.
So Patricia and Nancy are from the YMCA.
Yes, sorry, I meant to say that. YMCA, Delores Emotions.
Would you please briefly describe a workshop? What did it consist of?
Sure. Or Miss D, our master trainer. We should hold hands and stand up, right? Come on. So a workshop is 2.5 hours facilitated by people just like us. People who either have a chronic condition or who care for someone with a chronic condition in a room that has a minimum of 10, so we try to enroll a minimum of 15 because a third to 50% of the people who say they're coming don't come, right, Ms. D? We think we got to pray, oh my gosh. But then you're in this room with 10 people who, although they may be as different as night and day in their life experiences and their present moment situations, all share a concern about chronic health conditions. And tell a little bit about how it goes.
So that's what actually builds. I mean, you see a relationship form. Like you said, these are people that don't even know each other. So I may call them, friends or husband and wife or whatever, but these are people who don't know each other. But by the end of, I want to say, session 5, 6, it's like, wow, you just really see them just blossom. They be very excited. They learn about how to do action plans because there's a toolkit that we introduce them to. And the action plan is something that they have to do every week. These are short, achievable goals, whether that could be walking from their house, maybe 2 houses down and back, just little things to get them moving. It's wonderful. There's a relaxation component. We have a CD, and we do a relaxation meditation with them. These are like distraction tools, tools that we use for distraction, different things like that. So they learn several different things, and we give them different tools to help them to manage those conditions.
So to just sort of practically say what happens in a workshop, people sort of come in, and it starts out with self-management from the get-go. So people make their own name tags, right? We know who's supposed to come. There's a sign-in sheet, but we ask people to make their own little name tag with their first name. Now we recognize maybe not everyone can do that, and so one of the 2 facilitators will be right there at the sign-in desk. If it looks like somebody needs help, we give them help. But they set that platform at the beginning, and the facilitators set it because we share what our investment is in the process of either pain self-management or diabetes self-management or chronic disease self-management. Show that it creates from the get-go almost a climate of trust. Trust takes time. It's not right there in session 1. But as Ms. D said, by the time you get to session 3 or session 4, these folks have shared enough with each other that you're really 95% of the time, getting good, honest, practical advice. But the important thing about it is not medical. It is not about medical. In fact, we're trained to say, you don't give medical advice, consult your healthcare provider. What we're about is helping people to identify problems, solve problems, make decisions, increase their communication skills, and develop their own plans for what they want to do, choosing their own plans. And I would say one of the most common things that we hear when people finish a workshop is, this isn't just about my health. This is about my life. These are life skills, not just self-management health skills, and so they generalize across the age span, across the income and education levels, all of those sorts of things. Lots of talking, not too much lecturing. If we were in a self-management workshop, we'd be limited to how much we could say. We wouldn't be talking heads to you. We'd be engaging you in paired activities, group sharing, brainstorms, problem solving. So we just did a fidelity check on it. As a master trainer, we're supposed to do that.
Right, it's fun. It's fun. And it's, like you say, it's all about the facilitators, the co-leaders too. And when you have a chronic condition and you begin to share that with them too, that kind of like helps bring that wall down. You know, and it makes them a little bit more comfortable, you know, so.
And with an average age of 65, it helps if you have a gray head in there, in the group sometimes.
Is it a requirement for the facilitators to have a chronic condition?
Well, the informal requirement in the program is either that you have a chronic condition or that you care for someone with a chronic condition. How many of you expect that sometime in your life you're going to be a caregiver? How many of you think that sometime in your life you're going to need to receive care? Well, what it means is anybody who really wants to can qualify as long as they have good communication skills, they respect confidentiality, they have high ethics, and they have respect for persons. But it is important that you be able to share either your own personal experience with the condition or what caring for someone with a condition means. Because at the end of the day, it's all about real life lived experience. And how can you change that for the better? It's not just about communicating with your doctor or your nurse practitioner or your massage therapist, although that's really important. It's about every day, every minute, because at the end of that day, you will have had more to do with your health outcome than anybody else will. And if you're a caregiver, you will have had more to do with that person that you care for than any healthcare provider will ever have. And maybe that's why they're reluctant to refer to us. I don't know, just a thought.
Can I add to that too with the community health workers? That program is a dual certification program. So they get certified as a community health worker, and they also take this training because it is part of the curriculum. So they come out with their certification as a community health worker, registered with or through the Ohio Board of Nursing, and then they come out being certified to be able to co-lead. So we have 24 community health workers that are certified to be for that. Is that Christine over there? One of our students. We got one up here. We got a couple of them in the room.
So let's talk about our next steps venture that we're going to do together with Christine and maybe with you later. So Brianna has been saying from the beginning we need to do something with people who are in severe situations, many of them ex-offenders or suffering from one form of addiction or other kind of behavioral health challenge. So we are so excited. Christine and I are going to co-facilitate a session at the Hitchcock Center for Women. And we're very excited about that. And then Miss D is going to come in and do sessions 5 and 6, kind of like the fidelity one. I'm excited. Yeah, that's amazing.
Yes. And can I say something? I'm so quiet. Something else that I see too as community health ambassadors and community health workers, I see us as those, I want to say, you know, where the gaps are. I see us as those, get mobilized as that team of people for you all. stick us in those places where you see those gaps. We can be connected at the different clinics. We can be connected wherever you're implementing different work and you see that you're having a barrier or there's a gap. Remember the community health workers and our ambassadors, because that's where we are. Since we're connected with the community, we can relate sometimes on a whole nother level with your clients. And we really are. Mobilizing them strong.
It seems like so thanks for the presentation. I really enjoyed the team effort. This is really interesting. It seems like having the minimum number of people and like physically needing to show up into one spot is a big challenge. It's not that there's not enough trainers. It's not that there's need and interest. And it sounds like there's a little bit of flexibility for some of the programs. But I'm just wondering if you guys had alternative ideas about how to do it maybe differently. Like would it be possible for people to Skype in, like some people to be in a room and other people to join?
Well, here's the challenge. Of course, it's possible to do an adaptation. The adaptation is not evidence-based.
Yeah.
Okay, so exactly. So if a few $500,000 grants get done to go from a minimum of 10 to a minimum of 5, then maybe that can become an evidence-based program as well. But under the terms of the license, you can't deliver it other than in a fashion that demonstrated the evidence. Because, of course, if you did, and it compromised the outcomes, then you would be compromising the license. It's kind of like if McDonald's substituted lamb for beef, it might have a really good outcome, right? But a whole bunch of people would be unhappy and they wouldn't be in compliance with the license. But I think there are lots of things happening around this whole notion of evidence-based community practice that create responsible and responsive sorts of alternatives.
Did K-Work stuff ever look at the number of sessions to know, or number of people? So that's based on them knowing that if you get too far down, there's not enough people to...
Well, yes, it's based on their research suggesting that at this level, your aspects of achieving the desired outcomes are improved. And I think the reason for that, to me, and Stacy knows, this is one of my favorite sayings, one size doesn't fit all. And in a room of 10, you're more likely to hear something that fits 2 or 3 people in the room than in a room of 4 or 5. Do I wish that we could do it with 6? Yes. Do I think it makes sense to do it with 2? No. It doesn't make sense for 2 reasons. One is it doesn't make sense because there's not enough breadth of input. And 2, it doesn't make sense from a cost-effectiveness perspective.
And it doesn't make sense for interactivity because with 2 in the room, you're carrying too much weight.
And the notion is not that the facilitators are teachers or lecturers or experts. We're not. We're facilitators. Some of us may be firefighters, and some of us may be postal carriers, and some of us, like me, may be a renegade social worker. But it doesn't hang on that. That's not the reason that we're there and that we're doing it well.
You mentioned produce sites. Did you ever think of partnering with a food bank or Hunter Network to go to pantries?
We have some of our community health workers and ambassadors. They are connected to the food banks, and like I said, we just go to places. That's what I'm looking at. Where's the places where people are? Where are they coming
Pantries
together?
is a good idea, though.
You know what I'm saying? So yes,
We've been involved with the Stay Well program through Hunter Network for the past 6 years, and so that's it's really.
So we're a food distribution site. So we do 2 different kinds of programs. We do the USDA food boxes for about 140 people a month, and we do fresh produce distribution for the food bank. Both of those are through the food bank. And then we do an after-school program for children and families that's also through the food bank. And so that does provide a recruiting pool. But it's a recruiting pool that just happens to come to this site, right?
Bill, I think what you mentioned, have you guys connected to the Hunger Network's
So,
No,
I
I
speak
want
to that
to.
a little bit. So with some of the sites for the say, well, they're not in the reach neighborhoods.
Right. Okay.
And so
once it
that was
goes
one of
broad-
our initial
Got it,
things,
yeah.
was to go for that.
Just stay focused
yeah.
on those.
But the churches aren't in that. And they
Right.
weren't within like the 0.5
Got
mile
it.
radius and all that stuff that we had to
That
work
makes sense.
in. But going
And we're not
forward
in-
with future looking outside of reach neighborhoods, that is something now that I think we should develop.
Yeah.
And I know the Hunger, I'm involved with the Hunger Network and on their advisory board as well, so they are re-evaluating a lot of their sites.
Yeah.
So all this will change.
So what I'm saying goes that no pain, no gain. Luckily, in your workshops, pain index went up. Other than this, how do you measure gains for the workshops?
Well, you know, there's research and there's life experience. And for me, the most important measure is not the research. Yeah, we've got to have the research because it's important to build a constant base of evidence. But the most important outcome, the most important way to see impact is from the participants themselves. And the first way they show it is they keep coming back. They don't get paid to come. This is not the kind of research where they're picking up $25 a pop to attend the workshop. Once in a while, we'll do an incentive to get people to come that first time. Now, we didn't really do that in this particular situation, but it's they come back. And 2.5 hours is a long time to commit to. And guess what? We don't get to compromise the length of the time any more than we get to compromise the number of people that we need in the session. So that's the first measurement, is people are getting enough out of it to want to come back and to make the sacrifice that it takes to do so. But really, in the last 2 sessions, and especially the last session, there's the opportunity for people to say what their experience has been, and also to share for the people in that group, which has become sort of familial after a while, but to share for the people that might not have as much of a voice that they themselves project. So, you know, when you say, would you sort of share what your experience has been, that's one thing, but would you have something to say about what you've seen in anybody else in the group? And you're at a point by then in the group development where nobody's ever going to say anything negative, right? It's all positive reinforcement. And somebody might say, Cheryl hasn't said much, but have you heard her action plan reports? You know, it won't be me saying that. It'll be somebody that sat across the table from her for 6 weeks. Or somebody will say, look at how she's carrying herself now. It's like the weight of the world has been lifted from her shoulders. So for me, that's how I measure it. Now, I try to give Samantha what she needs. We try to do those pre and those post. And, you know, I didn't go to Berkeley for nothing. I understand all those analyses, right? But
The pain scale is pretty, I mean, the pain scale is pretty subjective, so it is a subjective.
And all of these are self-reported, right? But you know what? One way you look at pain is in how people carry themselves.
Yeah.
Because your pain might be in your elbow.
It still hurts.
But when it's bothering you, your elbow is going to make you slow, it's going to make you stoop, it's going to make you drag, it's going to make you
Well, I think
sit
too,
down.
if you're in chronic pain, and some of us are, you know, it's also like if your depression score went down, you know, my pain, this shoulder hurts today, tomorrow, every day. But whether it bothers me and interferes with my way I look at life, that's it. Because that pain is still going to be the same, and I may interpret it somewhat differently day to day, but, you know.
With that pain data, I immediately thought, oh, maybe they're more aware that there is pain. What they're feeling is pain.
It is real pain.
You know, yeah.
Well, and the other thing is, you know, when you peel an onion, it all depends on which layer you get to, right? There's the first layer, and then there's the second layer, and then there's the third layer. We also do pain self-management workshops. Mm-hmm. And one of my experiences in pain self-management workshops is as people's it's exactly what you said actually, as people get more of a handle on the other aspects of their life and their depression goes down, or they get more responsiveness from the healthcare provider because they've actually learned to ask for what they want to know, then they are more aware of their pain because their pain is the only problem that's left. Whereas before, there were all of these other sources of challenge on their worldview. But I also think we need to remember who we're working with. And sometimes it's not, did your pain decrease? It's, did your pain not increase more quickly than it otherwise would have? You know, it's sort of like with taking a medication. It can make you feel wonderful, or it can just make you not feel as bad as you would have felt if you didn't have it, right? So I think with any kind of an outcome variable, you really have to peel the onion and peel the onion and peel the onion to get a sense of what it means at one point.
Something else that I would like to share, something else that they tend to learn is how to communicate that pain at level to their doctors. Whereas before they didn't know how to communicate that, because like I say, they could say on a 1 to 10 scale, but during the workshop, we have a communication session, and it teaches them how to communicate that information to their doctors.
And their spouse. And their adult children.
Absolutely.
Yeah. And how to say no to fixing Thanksgiving dinner for 50 if they don't want to.
But the book itself has so much information in there that some of them even say that they're going to read it as part of their action plan. Yes. Wonderful book.
Very good, you
Thank you. Thanks everybody for attending. Hopefully we'll see you next month. But really enjoyed the panel. And hope to see you again. Remember to sign in on the sign in.